Welcome everyone to our wonderful presentation today. My name is Alan Wong. I am the president of the American Academy of Developmental Medicine and Dentistry. I'm a general dentist and I teach here at the Dugoni School of Dentistry. Today we have a very special program, people sharing from their heart as we move forward. I'd like to thank Dr. Seth Keller for helping produce this wonderful presentation. We have a wonderful panel that's going to help share with us where we've learned in the last 2 years. The American Academy of Developmental Medicine and Dentistry has 3 pillars: advocacy, education, and access to care. I think all 3 pillars will be met today, and I look forward to the presentation with our wonderful moderator, David Irvin. So with that, I turn it over to David.
Hey, thanks, Alan. Wow, how great to be here with you. My name is David Irvin. Happy Valentine's Day, first of all. It's a day for love, and we're glad that you are all here with us. My job is the moderator today, is to keep us focused and on task. We've got some great panelists here. We've got 90 minutes to cover a lot of ground. As we're going through, please ask your questions in the Q&A feature of Zoom. You can also throw it in the chat feature, but I don't want to miss it. So if you can, if we don't answer your question live during the webinar, do not worry. We will be collecting all of the questions verbatim. We will make sure that they are reflected back out to all of our panelists. In about 2 or 3 weeks' time, we will actually post answers to all questions submitted on our website. And we'll send those same answers out to each person who is registered for today's webinar. So that's good news. I'm going to get us going with some introductions, and I'm going to call on our panelists particularly for some very brief introductions so you know who you're talking to. John, let me start with you.
Thank you, David. Good afternoon, good morning, everybody, wherever you're from. My name's John Raphael. I am the Director of Educational Services at the National Alliance for Direct Support Professionals. I'm a social worker, but my role has been for the last roughly 40 years is to elevate the status of direct support professionals, those people that work day-to-day professionally with people with intellectual and developmental disabilities. So I'm just thrilled to be here. Happy Valentine's Day. Back to you, David.
Thank you. Ben, please.
Hi, I'm Ben Margolis. I'm a neurologist and psychiatrist. I'm providing neuropsychiatric care for adults with IDD in the Hudson Valley in New York at Access Supports for Living, an agency that provides comprehensive supports. And I'm a board member of Aadmd and double boarded in neurology and psychiatry, and honored to be part of the team, and really excited to be part of finding a way forward. Thanks so much.
Thank you, Ben. Kim, you're next.
Hi, I'm Kim Hing, and I am an autistic self-advocate as well as an athlete leader global messenger for Special Olympics Northern California.
Thank you, Kim. Emily?
Hi, everyone. It's an honor to be with all of you today. My name is Emily Hotez. I am an assistant professor of medicine and developmental psychology researcher at UCLA. I'm also the sister of an autistic adult, so I am both professionally and personally committed to our discussion today. My primary work takes place in the context of the Autism Intervention Research Network on physical health. And then, as you are well aware, the COVID pandemic magnified health disparities for individuals with IDD, and a lot of my work over the pandemic has responded to those disparities. And I look forward to sharing more about what I've learned from these and other projects with you today.
Excellent. Thank you, Emily. And by no means least, Peter.
Thanks so much for having me. I'm Peter Hotez. I'm best known as the father of Dr. Emily Hotez, but I'm also the father of Rachel Hotez, who has, as Emily says, is a 29-year-old adult with autism and intellectual disabilities. And my day job is I'm a professor of pediatrics and molecular virology at Baylor College of Medicine. I head a group that develops vaccines for neglected diseases and a new COVID vaccine that was just released for emergency use authorization in India. But in addition to that, because I'm juxtaposed in this unique way, making vaccines and having a family connection with autism, I wrote a book a few years ago called Vaccines Did Not Cause Rachel's Autism, which put me very much both in the autism community and also put me up combating a pretty aggressive anti-vaccine lobby. So it's kind of a backdoor entrance into this world, but it's a fascinating one, and I've learned a lot from Emily.
Excellent, excellent. Well, thank you all again for being part of today's conversation. I want to kick us off sort of in the time machine here. So we're going to step into the DeLorean and go back in time to really January of 2020, if not even sooner than that. And I am a provider during the day, a researcher, a pracademic, if you like, and what the system, such as I work in it, was prepared for against the backdrop of a global pandemic that hadn't been seen for 100 years or more. I would sort of characterize as was extraordinarily minimal, and I think that's being generous. Over the last 2 years, we have learned a lot, and many of those lessons have come through the most painful and extraordinary of circumstances. I don't want to spend a lot of time here, but I do think it's important to set this context. Peter, I'm gonna sort of turn to you first. And I should say, and I'm delighted that you didn't talk about it, and neither am I surprised that you didn't talk about it, but I've been watching videos of you on MSNBC for what feels like the whole of the pandemic, and have learned a ton just watching you on TV. When all of this started 2 years ago, there seemed to be very little chatter about the potential impact of COVID-19 on people with intellectual and developmental disabilities. As a dad, let alone as a clinician, as a researcher, as a virologist, we were ill prepared. What do we learn from that? Not that I want there to be a pandemic starting next year or a new global health emergency, but thinking back to 2 years ago, what should we have been paying attention to that perhaps we weren't? And as we lean into moving forward, should be paying attention to going forward?
Well, I think the biggest thing is that I think many in the community, even in the biomedical research community, didn't really fully understand that this could be a marathon. This was not going to be a quick outbreak that would run its course in a few weeks or a few months. That it was going to look more like the 1918 flu pandemic, which we called it 1918, but it really went from 1918 to 1922. And I think had we had that better understanding that we're in this for a few years, and there's going to have to be a system that's put in place of when the pandemic will worsen in waves and when it will be at its nadir and we can resume some level of normalcy. I think that would have set expectations, and then we could have prepared our population better for that. I think that's a big component. I think, once vaccines rolled out, I think many in the leadership in public health in this country were not fully briefed on how pervasive and powerful and organized the anti-vaccine lobby had become in the U.S. And so I think the thinking was once vaccines are here, we could vaccinate everybody, achieve 80-90% vaccine coverage, and ultimately vaccinate our way out of the pandemic. I think there was not that understanding that a good many segments of the country were going to dig in and refuse to get vaccinated. with devastating consequences. We've lost 200,000 unvaccinated Americans just since last summer who were defiant of vaccines. And I don't even know what words used to describe that. It's not misinformation or disinformation. It's the world's greatest self-immolation certainly this country has ever experienced. And we're still in the middle of that. We're still losing unnecessarily 2,500 Americans a day. And so the distrust in government, and of course, because that has helped to prolong this epidemic, now we're really starting to see a lot of unraveling in civil society, and of course, mental health at multiple different levels that we can talk about.
Yeah, thank you for that. And it will become a really good segue, because I think there's a lot of lessons learned around how well or how at all we are attending to significant mental health support needs among folks with intellectual and developmental disabilities. That's certainly a topic that we're going to spend some time on. Fast forward to just a couple of weeks ago, maybe even last week, Peter, I'm going to stay with you just for a second. We're aware, I think, that there's a I probably imprecisely call it Omicron's twin brother, sometimes referred to as the stealth variant. Just last week, you cautioned us to, against the backdrop of dropping masking mandates and other sort of public health policy, you cautioned us to pause a little. Let's wait for a couple of weeks to see how this particular variant is playing itself out. Anything in the intervening days to suggest a different approach, or are we still taking a watch and wait approach? And what do you think about masking mandates if this stealth variant is not a dangerous variant? Should we expect to see masking mandates be dropped all over the place?
Wow, you really did watch me on MSNBC. I didn't. So now we know. So exactly that. So I said, look, the numbers are going down as fast as they came up with this Omicron wave. And it's going down the fastest now in New York, New Jersey, and Washington, D.C., where it first went up. But then I put the brakes on things a week or so ago, because I said we still have this subvariant known as BA2, which had the effect of slowing down that deceleration in the UK and in Denmark, and where it started going back up again. So I said I'm kind of holding my breath to see what happens with BA2 before I say the numbers are going to continue to decline. The good news so far is in the ensuing week, the numbers are continuing to decline. We've not seen big effects of BA2, if anyone, a different variant, B1.1, and the numbers are coming down precipitously. So now we're about 25 new cases per 100,000 in New York, New Jersey, Washington, D.C. It's about 4 or 5 times higher in Mississippi and places like that, but it's still coming down. So that gives me some reason for hope that this wave could be coming to an end. And once we get, below whatever cutoff the CDC feels comfortable with, maybe 10 per 100,000, so it won't be long in New York, New Jersey, and Washington, then I think that masks can come off in indoor settings, at least for a period of time. And I caution again, because we've failed to vaccinate the world's low and middle income countries, and that has thrown off terrible variants last summer in Texas and the southern states, and I think that could happen again. But the hope would be the best case scenario is those numbers continue to decline. We get at least a few months break in this COVID-19 epidemic in the United States, let the kids finish that spring semester, and then two things could happen. One model says that we should expect seasonal waves every winter, and maybe this Omicron wave was the first one of that, so that would be good for a year. Or because we have failed to vaccinate the world's low and middle income countries, Mother Nature is going to throw out a new variant of concern over the summer in the southern states and Texas.
I hope you are wrong, but we should all be vigilant. Kim, I'm going to turn to you. You bring such a wonderful perspective to the conversation, because you've lived through the experience of trying to navigate these last 2 years. And I wonder if you might just be willing to share how you've experienced the 2 years just gone by, we'll ask you what you think we should be thinking about going forward. But if you go back in your time machine to 2 years ago and just walk us through your experience of the pandemic, I think it would be very helpful.
Sure. Thank you. I work at an after-school program. I teach second and third graders, language arts and math. And we had parent-teacher conference like in the fall or like around Christmas time kind of. And some of my students are immigrants from China. And I was speaking to one dad and he was talking about how the Chinese New Year celebrations were probably all going to be canceled in China. And that's a big deal because the Chinese New Year is a huge celebration in China. And I said, oh, why is it all going to be canceled? And he told me that there were this illness, and I don't know what it was. He didn't really say what it was. There was just this illness that's killing a lot of people, and so like some of the cities were completely shut down. And so I thought, okay. But then I didn't really think too much about it, which I should have, because I thought, well, we're in the United States, we're really far from China. It's not going to affect us. But I guess in hindsight, if I think back, there are so many immigrants from China that there's a lot of back and forth travel to China and back that I guess, and people from other countries too go back and forth. So to me, I guess in hindsight, it was obvious why it would have spread to the United States. And then once it finally did hit, I remember in March, like our the owner of the after school program told us that we were going to have to start wearing masks, but it wasn't a lockdown. And then like 2 days later, she said, okay, we're all going remote. So no more in person, anything. And we all immediately had to adapt to things that we'd never used before. Teaching remotely. I didn't have internet, so I had to get internet and just a lot of things like that. And once we had to, well, in California, we had to, what was it called? Shelter in place. And I actually didn't mind sheltering in place, and I loved working remotely because I like just staying in my apartment with my cats, and I like, working remotely. I don't have to, well, my commute wasn't far. I just had to walk across the street. But I mean, it was just easier, and I can do things on teaching by Zoom that I can't do teaching in person. And it worked for me because my class size is small. I did not like that Special Olympics canceled all its in-person programming. We had soccer and flag football in the fall. We were going to have basketball, but it got canceled because of Omicron in my area. I guess there's some other areas that are doing basketball. So we're waiting to see if we get to have spring sports. So that shutdown was a big issue for me because, my friends are with Special Olympics. That's where I get a lot of interaction and acceptance is through Special Olympics. Mm-hmm. But Special Olympics Northern California was really great about having a ton of virtual programming. And that was good because I got to make friends and see people from other parts of California that would never have happened. I know for me, having to do all this isolation for such a long period was not that big of a deal, but I know for a lot of other people, it was very difficult for them.
Thanks for sharing that. I was about to ask you about that sense of isolation and whether that was something that you experienced. It sounds like it wasn't at least as significant for you as we're aware it was for other folks. Well, because I interact mostly with my students at work and then with Special Olympics.
athletes and staff and coaches, I don't have a lot of interaction with other people. So we were getting a lot of, through the virtual programming with Special Olympics, we were getting a lot of things that way. So it worked out okay for me.
I would observe, just this is for the benefit of the panel, would love your comments on it as appropriate. I happen to work at an organization where we support folks in a whole range of community living supports. And the feelings of isolation and disconnection became quite palpable, not just for folks with intellectual and developmental disabilities receiving supports, but for staff who were working with them as well. Because what did we do? We sort of stopped being the social creatures using typical platforms on which we connect with other people. And so, as I mentioned earlier in response to something Peter said, we really need to lean into some of the behavioral health impacts of what these 2 years have given. Ben, let me turn to you in that context. And in full disclosure to everyone listening, I'm aware of Ben's work and appreciate very much, in fact, that some of the focus that Dr. Margolis has had during this time is to truly understand, or to meaningfully understand using data, what are the behavioral health manifestations of this lockdown sort of environment in which so many people with IDD have lived for so long. Ben, I thought you might comment on what you learned about, through your research, about the experience of people with IDD and their caregivers over these last 2 years. And then we'll use that to sort of pivot into, okay, what's next? How do we embrace lives of abundance, knowing that we've learned some valuable lessons in these last 2 years?
Great. Yeah, I'm really happy to share what we learned teaming up with colleagues from the American Academy of Neurology Special Interest Group, the interest group in IDD, clinicians, our internal clinician network, colleagues, friends, and teaming up with Dr. Solomon Sanders at the University of Colorado, you said. So what we saw, of course, all of us observed pretty much the same thing. Everybody's doing terribly. And it really seems that people with IDD and their caregivers feels like they potentially are doing worse. And we saw that rapidly and suddenly in the clinic. We saw it personally. And none of us knew of any time when suddenly services were interrupted. We saw not only the interruption of services, but we saw significant declines among our patients with IDD in functioning in terms of old challenges that we had figured out how to tackle were returning, new challenges, new behavioral problems, all sorts of ways of expressing anxiety and depressive symptoms really significantly emerging rapidly. And so many things were happening at once. There were so many factors contributing. We wanted to be able to not only capture and demonstrate this is what happens when services are interrupted, which was potentially, our kind of working hypothesis. What is it exactly about the changes in the pandemic that may have contributed the most to what we saw, and was what we were seeing potentially real? Versus just our anecdotal experience. So we teamed up with epileptologists, psychiatrists, community providers, agencies locally in New York with Special Olympics New York, Special Olympics Colorado. We adapted the Crisis Afar survey, which came out of a consortium, Nathan Klein Child Mind Institute, which was a survey to capture the mental health impacts of COVID-19 on individuals with developmental changes. We shortened that survey and deployed it in 32 states. It was a convenient sample. We saw several other groups doing similar work. specifically with children with autism. With autism, there were caregiver surveys. Our surveys was a survey for individuals to answer themselves versus or for caregivers to answer for them. We asked questions about access to services. We asked questions about how individuals were doing, whether or not you started new medications, and what kinds of services and activities you have that changed during the pandemic. We got about 500 responses from 32 states, and what we observed and learned is that the biggest correlation between self-reported symptoms of or markers of anxiety and depressive symptoms, the biggest correlation came from interruption of services and programming. Hands down, that was it. The paper is submitted and pending, but people got worse when their services were interrupted. We also saw, curiously, and we observed this, is that there were a small number of people, about 12% of our sample, but there were a small number of people who really got better during the pandemic. And some of us observed that among the people I work with. It seemed like people who are more significantly affected by autism and intellectual disability, some of the people who were most significantly affected potentially didn't like going to program, potentially really enjoyed nesting, and didn't need so many, use of PRN medications. Markers of behaviors went down among this group. And so I thought, we learned potentially that there is a subset that we need to pay closer attention to that maybe really does best outside of what we would maybe assume would be socialization and good for them. We need to listen to that group, identify that group. And we don't have the power to be able to say what really was protective for this group. But that's my hypothesis and prediction. And I'm hopeful that future work will be able to identify people who really don't necessarily need us to assign programming to and assign transportation to, because maybe it's not great for them.
Right.
And I think those are the people that didn't have a way to tell us before. And this is how we heard. This is how we learned to listen. Oh yeah, Kim, so. Sorry,
I think I'm in that category.
Yeah. So then, I think one of the things is some people are very social and they don't understand it if other people aren't that way. And I'm guessing they might think, well, you need to get out more. You need to learn this. You need to, et cetera, et cetera, et cetera. But if you're not in an environment where you're around people who can accept how you are different and things that you do that come up, like you might say things and it might rub the person the wrong way, but you're not really doing it on purpose. And if you're in these situations, I'm speaking as someone who's autistic, it's you just don't, you get tired, right? And you just don't want to deal with that, and you're not comfortable around it. And so it's just much nicer to stay at home with your cats who understand you and aren't being critical of you and not taking things the wrong way.
It's the age-old sort of mantra that we need to embrace more and more robustly, and that is ask, don't assume. How do people seek to experience their lives is a heck of a lot better than me making assumptions as to how they'd like to experience their lives. I want to be sensitive to.
Beautifully put. I'm sorry, David. I didn't want to. I didn't want to interrupt you. No, I so appreciate what you said, Kim. That bridges to what we're to the last part of David's question about how we can move forward. And so thank you so much for being so able to communicate and helping us. I'm going to bridge exactly what you were talking about later on. I want to make sure that I address the second part of David's questions. Still the first, which is what we learned. So there was 12%. There was a small group of people that did quite well, but the majority of people didn't. And what we saw is, I saw in clinic a large number of people who would come requesting PRNs, family members, staff members, support staff and individuals themselves with developmental changes, asking for help with related to their panic. We saw medication kind of medication burden, if that's okay to say, potentially increasing as a result of some of these symptoms. And so what we learned is potentially that the supports that you are talking about of tailoring how to stay connected may be something that we can offer and pay attention to going forward, rather than using psychopharmacologic interventions. While that's not, and we can't necessarily capture and compare using what we learned as far as prescribing practices. That data will come when we look at Medicaid data and see how many people with IDD diagnoses were prescribed new medications at a greater rate than were before the pandemic. That data is forthcoming, but I can sort of, from a hand waving and anecdotal perspective, propose that what we learned is we learned potentially that there are multiple ways to not be physically with other people, but not to be alone. Exactly like you said, you may not feel comfortable in a one-to-one environment, but that we came up with brilliant and creative ways to provide programming for individuals that, like you said, with Special Olympics, all kinds of online programming to help people feel connected. And I think that really helped to mitigate what we saw at the beginning of the pandemic during the months we worked. In addition to what you talked about, what do we do going forward? I just want to highlight what we also learned, and what I learned as a clinician is how vulnerable and how essential direct care professionals are. And what we saw is we saw tremendous changes in staffing, and we saw how vulnerable our individuals are to the discomfort that goes with changes in familiar staffing. We saw, and I think I'll defer the specifics of how hard it was for direct care community. But what we saw was the increase in medical and behavioral and mental health needs directly as a corollary to, directly as a consequence of the removal of the kinds of supports that were provided by direct care professionals. I'm sorry, go ahead. Yeah.
Let me interrupt you. I'm sensitive to time, and we're getting.
Oh, I'm sorry. Yeah, thank you.
Lose Dr. Hotez. And so, Peter, before we lose you to competing, I'm sure a schedule that is lovely to behold each and every day, and before turning to the other Dr. Hotez, I wonder if there's a couple of questions in the Q&A feature that are clinical in nature. I don't want to presume to throw them at you, but the first question I am going to throw at you before we lose you. It's a mom who speaks to a 33-year-old daughter with autism, and she's worried, as many parents are, perhaps even you are, as a dad. We're so desperate to get out of this isolation, and yet we're terrified of the potential of contracting COVID. What advice might you offer to that mom and other parents who are listening?
Yeah, I mean, we had the same thing because, Rachel, who's 29 years old, works at Goodwill 2 hours a day, and even though they have a mask requirement at work, sometimes she would have trouble complying with it, and of course we were worried she was going to get COVID and of course bring it home to us. Less so after everybody was vaccinated. So I think the first message is make certain that your 33-year-old daughter is fully vaccinated, and forget that 2-dose stuff. You want to get 2 doses of mRNA and then get boosted with that 3rd dose. So I think that's probably one of the most impactful things you can do while transmission is still high. If she's working outside the home, if she can wear a mask at her place of work, and if other people are masked, that will also help. And so it's not very complicated. It's vaccinating everybody in your house to the maximal extent possible, including the other kids that might be in the home, and having people wear masks in indoor settings when they're outside the home, at least while there is this still very high level of community transmission, although now coming down significantly.
Thank you. And lastly, before you run, you want to weigh in on the debate over what's the right masking for people? Is it indeed the N95 that offers the most significant protection so that when this mom is buying masks, she knows which one to buy?
Ideally, yes. I mean, there's no question, you know, either an N95 or a KN95 is like this is optimal. It's also the least comfortable, right? And especially for special needs kids, it's really tough to get Rachel to wear something like this. I mean, it took us a long time just to go with the surgical mask. And so I would say, you know, a practical lesson is don't let the perfect be the enemy of the good. If it's a matter of, you know, you send her out the door with this and she comes home without it and knowing that she didn't wear it, there's no point to this is better than nothing. I mean, what I tend to do is when I'm in the office and close the door, no one's around, I don't have to have a mask on. But when I'm out in the hallway now with this Omicron variant being so highly transmissible, I'll actually wear this and put this on top of it for an extra layer of protection. It's not fun, right? It's and you know, to walk around like that all day. So you know, with special needs adults and kids, this is all they'll wear, it's certainly better than nothing, and much better than a cloth mask.
Excellent.
Dr. Hotez, before you leave, can I ask you your comment about therapeutics and what's out there?
Well, there is a very good new drug from Pfizer. It's called Paxlovid, and it works by interfering with virus replication. The problem has been it's not been available in abundance. It's getting there. It'll be in a much better place. But also remember that that you have to give it early on. So the COVID-19 has two phases: the virus replication phase, which is early on in the course of the illness, and then the inflammatory response. So the longer you wait, you kind of lose your window of when those therapeutics will work. So both Paxlovid and now there's a couple of monoclonal antibodies that are working. There's a couple of monoclonal antibodies that are not working against the Omicron variant, and those have had to be withdrawn. So you want to make certain that you're dealing with a healthcare provider who understands which monoclonals are working, which not. Most hospital formularies and pharmacies are on top of that. The small molecule drug is great, Paxlovid, because you can take it orally, and again, it's not always easy with some special needs adults to get to, for a monoclonal, to get them to go to an infusion center and get that monoclonal antibody. But if it's necessary, it's necessary. And the new one from AstraZeneca may be formulated in a way where you don't necessarily need that infusion.
Thank you, Dr. Hotez, for your continued advocacy, and I hope everyone heard quite clearly vaccines and boosting is it is the best tool that we have, and it's a pretty darn effective tool. I'm paraphrasing you, Dr. Hotez, but I appreciate your reminding us that this is the way we get through this.
All right. Well, thank you, and thank you for all your advocacy for people living with IDD. And Emily, I'll talk to you when I talk to you. Love you. Bye.
Love it. This is the perfect segue, Emily. I'm gonna pivot to you. John, don't worry, I've not forgotten you. So Emily's work, it occurs to me, is systems work, and I want to focus just a little bit on in addition to everything else that you do, I want to focus on sort of the core elements to what has been exposed as a result of the pandemic. And I think really there's two things that deserve a little bit of attention. I would love your comments. One is that COVID-19, when combined with the health disparities with which a community of human beings who happen to have IDD tend to this is not a homogeneous community, of course, but tend to interact with, has not combined well, and it has created and caused far more severe outcomes, including death for folks with IDD when compared to others. It also, sort of riffing off of Ben's commentary, appears to have quite dramatically impacted some, not all, people with IDD and their behavioral health and mental health needs. The disparities in the first place are not in dispute, I don't think. There are some who have said this absolutely lays bare any sort of further debate over it, if there is one. But what do you make of COVID-19 illuminating these disparities? And what do we do with it now that we know it irrevocably? What do we do with that information, and where should we start pointing our attention so that we can start getting back to lives of abundance?
Yeah, great question. You know, just as you said, having an IDD emerged as one of the strongest predictors of contracting and dying from COVID-19. And I don't have to tell this group that. But the disparate impact of the pandemic on this population is just one of many disparities that this population faces across the lifespan. So, for example, autistic individuals like my sister are disproportionately likely to experience cardiovascular disease, diabetes, anxiety, depression. They're more likely to report lower quality of life and lower life expectancy. And these disparities were rampant well before COVID-19. And that is why, in particular, my team here at UCLA, and I work with a number of interdisciplinary physicians and psychologists and researchers, we were astounded when the majority of people with IDD were excluded from those initial vaccination priority guidelines. We thought with all of these health disparities, for sure, they should be prioritized for vaccines. And so that really led us to do a really deep dive into the potential reasons why this might be occurring. So we know that people with IDD are more likely to have co-occurring conditions and more likely to have heightened service and support needs. But what we learned during the pandemic is there are many contributing factors that we don't consider that really contribute to health disparities. And these really came to light for me and for my team here at UCLA. And so I'd like to kind of tell you a little bit about what we learned over the course of the pandemic and some suggestions that that came about from learning these lessons.
Let me interrupt you just long enough to point the audience to the suggestions part of what Emily's going to talk to us about, because we're going to get to a point in today's webinar where I'm going to ask these guys, what do I do when I show up at the office or in my community or at my healthcare facility? What do I do tomorrow? Because the webinar is living well during COVID, which means that we can engage policymakers on things that we should be doing to live well during COVID and any other global health emergency. So pay particular attention, Emily, to the suggestions, because that's what I want to equip our audience with to what they do tomorrow.
Sure. Well, I have what they can do tomorrow and what they can work on for their entire lives. So maybe there can be a little bit of a merging. But what we found, one of the reasons why we believe people with IDD were excluded from those initial vaccination priority guidelines is that they are largely excluded from research. And something that I've been really prioritizing over my career as a researcher is collaborating with autistic individuals in the development and design of research studies. But that is certainly not the norm amongst researchers. And it's not even the norm to have a good representation of people with IDD as participants in medical studies. So we have a long way to go there. There was a study that came out that looked at the representation of people with IDD in medical randomized clinical trials in the top tier medical journals And it turned out that only 2% of those studies included people with IDD as participants, even when they could have been included with minor methodological tweaks. So if they are not included in research, policymakers really don't have a lot to go on when they're making their decisions.
That's an advocacy angle. It's an advocacy angle that you're suggesting. Get busy in advocacy and getting folks with IDD involved in research.
Well, the first step is to include them as research participants and try to ensure that your eligibility criteria for research studies is inclusive, not discriminatory, and isn't needlessly leaving out people with IDD as participants. The next step, and something that I believe is equally as important, is authentic, meaningful collaboration with people with IDD in the design of research studies. Because so many of our research studies are testing outcomes that are really not valid because they're not meaningful or important to the IDD community. If we had input from the start about their priorities and experiences and what their needs are, then we would make sure as researchers that we are studying what is actually important to improving their quality of life. And I believe that that would make a big dent in the health disparities that this population, of course, faces always, but would have mitigated some of the health disparities that they experienced during COVID as well.
Absolutely.
And something else that came up over the course of the pandemic is that the vast majority of physicians, while very well intentioned, simply did not receive IDD specific training in medical schools. And that's understandable. There are so many competing priorities in medical education. I never went through medical school, and I am in awe of the amount of curriculum and the amount of content that has to be covered. But the truth is that IDD, physicians leave medical school uncomfortable with providing care for people with IDD.
Yep.
And during the pandemic, their support needs were heightened. Their healthcare needs were heightened, and that our healthcare professionals simply didn't have the experience or training necessary to respond to them. So we're really working here at UCLA to build up a curriculum focused on the IDD population. And we're working with medical students across the country who are doing the same in their medical schools. So to the extent that you are a medical student and you'd like to build up a program that focuses on IDDs in your school, there are opportunities for you, and please do reach out to me. And finally, physicians were not always physicians. Physicians were people. They were children growing up in the world. And my lifelong experiences with my sister, and then now as a developmental psychologist who's reading lots of research studies, it's clear that there is lifelong interpersonal, educational, vocational stigma that occurs across the lifespan for people with IDD. People as young as 7 years old already have negative attitudes about people with IDD. And research shows that people who have these negative attitudes are less likely to associate with people with IDD over their lifespan, less likely to want to socialize with them or learn from them, and the gap just widens over the life course. And so by the time medical students are ready for their training, they likely haven't interacted with a lot of people with IDD. So this lifelong stigma is something that should have been addressed before the pandemic, of course, but I recommend efforts that are really developmentally focused and seek to prevent stigma and misinformation and bias before they even develop, and that's in childhood.
Yeah. Excellent recommendations. I will quote Winston Churchill by way of saying, never let a good crisis go to waste. And COVID is compelling for lots and lots of reasons, not the least of which is we now have profound purpose in advancing these conversations. To Emily's recommendation around medical schools, there are people in our audience who are not clinicians, who are not medical students, who are advocates or family members. You still have a role to play. And I would argue a very critical role to play. Advocacy takes many, many different shapes and sizes. And you don't need any letters after your name to be a really effective advocate. So Emily, thank you for those suggestions. John, you've been patient. I'm stealing this from you because you provided it to me and to others.
Okay.
John F. Kennedy is quoted as saying, "Quality is defined at the point of interaction between a staff member and a person with an intellectual and developmental disability." That's a pretty straightforward, simple, and yet very effective statement. DSPs have had such an interesting experience through the pandemic, mostly forgotten about, as we have celebrated healthcare workers, and rightly so. Dr. Wong, Dr. Margolis, Dr. Hotez, Dr. Keller, who's with us listening in, have done heroic work. And yet so too have DSPs in relative silence. NADSP has worked for years to advance the cause of professionalizing this work. And I'd love you to comment on how we've experienced COVID, not necessarily to languish in the past 2 years, but what have we learned that we can take forward in advocating on behalf of our DSPs who are at where the rubber meets the road when it comes to supporting people with IDD?
Well, David and everybody, we've learned a tremendous amount. We at the National Alliance for Direct Support Professionals, our job is to elevate the 1.5 million, I'll say it again, 1.5 million direct support professionals, and that's what we think we know. And I'll tell you why in a second, why we think we know that's how many direct support professionals support people just with intellectual and developmental disabilities in the United States. And what happened when our lockdown occurred, when the plague hit us, we started to mobilize because we knew at the National Alliance that these 1.5 million direct support professionals and the people that relied on these direct support professionals at that point of interaction every day, they were in for a challenge. They were not only in for a challenge just because of the pandemic and COVID-19 and, you know, the early days pre-vaccines when we were washing groceries and, you know, you were wearing gas masks and we didn't know anything about this terrible virus really to speak of, but we did know it was affecting lots of people and lots of people with intellectual disabilities, especially in the beginning stages. And it's these direct support professionals who have been historically devalued as a profession, misunderstood as a group of professionals. And what we did, we mobilized. And like you said, a good crisis, don't let it go to waste. We worked in partnership with the University of Minnesota, and over the course of 3 or 4 surveys throughout the pandemic, we got well over 10,000 responses from direct support professionals about their experience and the things they needed and the things that they were missing. And we have compiled all that. We have reports on that. I'm not going to get into the specifics of these reports, but the reality is a curtain was lifted, right, on a workforce that is not only underpaid, but under-recognized and in fact invisible. And one thing you said, the heroic, right? That's a double-edged sword, heroic, because I would go by, you know, group homes and I would know, you know, that maybe this was a group home where direct support professionals worked. There'd be signs, heroes work here. None of the direct support professionals that I surveyed myself, probably 100 direct support professionals throughout this pandemic, none of them thought of themselves as a hero. Mm-hmm. What they thought of themselves is as somebody that needed to show up to protect and support the health and well-being of the people that they were supporting, knowing full well that they might themselves be at risk for acquiring and contracting COVID, bringing it back to their families, all the stuff that we know. But I think the main thing that we learned and what we're going to move forward with, we now know this is an essential workforce. There were dozens of states where we had to help fight the state governments to allow for direct support professionals to take public transportation to go do their work because they weren't considered essential because they were invisible. We're no longer invisible, David and everybody. We're no longer invisible, and we're going to use this in legislation and policy making. And I'm not going to get into the weeds with that, but what we're doing this year specifically, we are going to rally for a standardized occupational classification for direct support professionals, which doesn't exist. They need an identity. And that's primarily what we got out of this pandemic, and we're going to use it.
So one of the things before we break today, John, I'm going to ask you for specifically, what do I do? So tomorrow morning, I'm going to wake up like I typically do, and I'm going to come to the office. And I work in an organization that employs a whole bunch of DSPs, and I'm going to ask each of our panelists, so stay tuned, everybody. Don't fall asleep yet, because I'm going to ask each of our panelists to give us a recommendation. What do I do tomorrow? Who do I write? What advocacy work can I engage in? What research framework, to Dr. Hotez's commentary earlier, how do I get people involved? I'm looking for tangible recommendations from each panelist on what we do tomorrow. We'll get there. So stay tuned, everybody. I do want to acknowledge lots of excellent questions in the Q&A. Thank you so very much. Some really great questions in the chat. Chat's a little harder to keep up with. If we don't answer your question, please know that we will reflect these questions to our panelists. We will amass answers, actual answers, and then we will send this back out to every registered attendee at the webinar. So if we don't answer it live now, don't worry. We will get back to it. Kim, I want to turn to you. John just spent some time talking about DSPs. You described your experience of COVID as living in your apartment, relatively satisfied to do so. Thank you very much. Hang out with your cats. For people with autism or people with IDD or self-advocates who don't have DSPs, who aren't supported necessarily by direct support professionals, but are still receiving services and supports. You mentioned that you got a lot of virtual supports. And you said in your comment that when those virtual supports were first starting to be offered to you, you didn't have internet access. And it occurs to me that technology becomes a big darn deal when you're pivoting from services that are delivered human to human, and instead you're sitting behind a computer. How did you go about getting that internet access? And how have you found the use of technology to maybe even change the way you think about being supported?
I live in Silicon Valley, and a lot of people just assume everybody has internet. There is a huge portion of people, like, what is something like in California? I heard the statistic, I'm not sure if it's accurate, but only 66% have internet or something. I mean, there's just huge number of people that don't have internet. They even found this out as far as like the technology, having the computers and internet when the schools had to go to remote. They found out, oh no, we have all these students who don't have internet and don't have technology. I think that if you tried to find out how many people in the IDD population have internet and the technology to take part in any kind of virtual programming, that is a huge issue, because I think there's many who don't have this technology. I didn't have internet, and I don't remember why or what happened. I think I got a text or something that said Comcast was going to be offering internet, if you were low income, to anybody within a certain income range for $9.95 a month. And before that had only been offered if you had a child on the free lunch program. So this made an enormous difference for me. I don't have a lot of money, and without that, I would not be able to have internet. So these are big considerations that need to be addressed. I know there are rural areas that nobody has internet because the infrastructure is not there. So what happens for these people who live in those areas? I don't know. But I think that a lot of work needs to be done to ensure that people in the IDD population have access to the technology. Maybe not a computer, maybe that's too much, but a tablet is certainly doable. And I know at Special Olympics, everybody has a smartphone. Everybody's, doing their thing on their smartphones. I know plenty of people do have tablets, but there's also a large portion that don't have that. Am I answering your question?
No, totally. And it illuminates, thank goodness you were able to get internet access. But imagine people who live in those rural areas, or people for whom even internet access is you can't afford it. We end up leaving a fair number of people outside of supports. The Coleman Institute, for many of you in the audience, you'll remember and know well, the Coleman Institute on Cognitive Disabilities, it's out of the University of Colorado. Some years ago, they published a statement on the rights of people with cognitive disabilities to technology and information access. And it, in essence, says that as a fundamental, basic civil right, if not a human right, given how ubiquitous technology is, that people with cognitive disabilities, including people with autism, including people with intellectual and developmental disabilities, must have access to the very technologies that the rest of the world literally take for granted. So I'm so thankful that you were able to get access to that technology, and there is already in place an advocacy tool that we can use available through the Coleman Institute on Cognitive Disabilities. So thank you for sharing your experience.
I just want to make one other point, because you are asking me about people who aren't in the group homes, but I don't know. I mean, John, you could probably answer this better. How the group homes are set up as far as internet and computers, tablets, that kind of things, because some group homes are big, some group homes are small. I kind of, in my head, was thinking, do group homes have like a little technology corner or something with computers and things that people can get on, or tablets that people can use? I think maybe people in group homes have just as much difficulty with technology access as people aren't in group homes.
I can certainly
comment. Yeah,
I can certainly comment on that, absolutely. And it really depends, Kim, on the budget that an organization might have that runs these group homes, right? But the reality is that most organizations did mobilize to find ways to get technology into the hands of the people that were supported in an organization, but also the direct support professionals, right? And there's one more little different side to the use of technology in supporting people with disabilities that direct support professionals told us they were worried because it was isolating. It was isolating to be, kind of stuck in your home to begin with, but then to be whatever programming that you might have taken part in throughout your week. Maybe you went to a day program, that day program was closed, and then you were now getting, Zoom or FaceTime sessions with your direct support staff. Direct support staff were worried that goes opposite to what our mission is to get people involved in interaction and building friendships and maintaining relationships face to face. And it became a very a razor's edge, right? Our balance. But you had to isolate. We all did. Look what we're doing here. We're doing this Zoom thing. This is weird. This is really weird, but we're all doing it. But I would much rather be with all of you. Kim, I'd rather hang out with you and have this conversation than look at you in a postage stamp size screen. But that's what we had to do. But
at the same time, just to interrupt you, we all live in different parts of the country. So I think learning how to do this virtual stuff brings people from everywhere to expand the whatever. I mean, the opportunity, like I probably would not, are you in New York?
I'm in Woodstock, New York. Yeah.
Yeah, so the likelihood of me being able to get to New York is 0. So it wouldn't happen. So this does give the opportunity to at least get together, even if I am in a 2-inch by 1-inch rectangle.
Yep.
I guess there was a comment about people with IDD needing tech literate staff. And yeah, that is something I'm sure if you have not had, anybody who's not had access to technology is going to need somebody to show them how to use it. So my mom is 85 and she struggles just using email. So, I mean, it's not just the IDD population that has, difficulty using a computer or a tablet. So don't think that, we are so different. Anybody needs it. And given patients and somebody going through the things, the IDD population can learn how to use this type of technology. And if they can't, I mean, a lot of times on Special Olympics calls and somebody is with the person helping them. So maybe they can't do it on their own, but why can't somebody help them?
Absolutely right.
Get on a Zoom call or whatnot. And then I just wanted to make one other little comment about John saying that trying to get people to interact with others and being isolated in homes, limited it. There are, group homes is not just one person living at home. There are other people living in the home. It's going to vary depending on the size of the home. But once day programs were not available, then the group home is isolated. So I think going forward, group home providers need to have some kind of a plan for activities and things to do that the people living in the group home, otherwise you're just going to be sitting staring at walls. So there has to be something planned in the back of your head that you can pull out to have people be active.
So it's a good turn for us. How do we live well during COVID is to have contingency plans, backup plans. If plan A can't work for whatever reason, and remember, I'm a provider, so what Kim says is like hitting me right between the eyes, because I will tell you that this provider, small little provider in the DC area, had to make it up as we went. We were not prepared for anything close to this sort of significant event. And while we're happy that we were nimble enough to respond, maybe one of the things that we learn about living abundant lives of joy and happiness and preparedness is that you plan for the worst, hope for the best, and have your plans ready to implement. Ben and Emily, I want to turn to you both. We've talked, Ben, you talked a little bit about mental health, and Emily, your systems view I think is really fascinating here as sort of a backdrop. Here's what I worry about. You're allowed to tell me that I shouldn't worry, but let me tell you what I'm worried about. I'm worried that a person's mental health, or the mental health of the community where I spend most of my time, is a lagging indicator of the impact of COVID-19. And what I mean by that is whether it's feelings of isolation, I don't know about the rest of you and folks in our audience, but I'm desperate to be among people, just to be among people, to enjoy the three-dimensionality of my fellow Homo sapiens. I have access, because I have privilege, to all sorts of behavioral health and mental health supports. What do we need to do? Emily, I'll start with you. What do we need to do to focus resources, not just on building behavioral and mental health supports for people with IDD broadly, because we need to do that. There's no doubt about that. But what do we do with the immediate needs of a community of human beings with IDD who have experienced feelings of isolation and separation and anxiety and depression at rates that arguably we're not completely familiar with? what do we do through a systems lens? And then Ben, I'll ask you to answer it through a clinician's lens.
That's a great question. One thing that my team at UCLA and I have increasingly realized is the importance of rupturing silos and working in interdisciplinary teams. And this is really from the perspective of direct service providers and healthcare professionals and doctors and researchers and psychologists, all the people who seek to serve people with IDD. There are countless populations who are marginalized. I've been working quite a bit over the pandemic to understand the ways in which the experiences of the IDD population are distinct from that of other marginalized groups, such as people of color, but also where the overlaps are, and how do we work to reduce disparities by taking an interdisciplinary lens. Not just viewing the IDD population as a totally distinct, separate population that's floating in the clouds, but one of many marginalized groups. And I think that would really leverage resources effectively and serve people with IDD more than simply viewing them as kind of a monolithic, separate group.
Yeah.
And I'd like to go back to one thing that Kim said, and that is something I'm going to quote you incorrectly, but something about how people with IDD are not that different from the rest of the population. And, obviously there are, as I mentioned before, countless differences, but there are many policies and practices that will work for the general population, will better serve the general population, and will tackle health disparities for the IDD population. So what we at UCLA are thinking about is neurodiversity-oriented healthcare and research. So what do I mean by that? I mean that we should be interrogating outdated healthcare practices and policies and maintaining a flexibility and an openness in our patient interactions. Going back to something that was said earlier, listen to your patients. Foster self-advocacy and empowerment in your patients by, of course, speaking to them and not just their caregivers, which is something that so often happens in the IDD population. Respond to individualized needs. Take a precision health medicine approach, essentially, a tailored, individualized approach that's really responsive to individual needs that are happening on the ground. I really think both this combination of working in an interdisciplinary team with those who seek to serve marginalized populations and maintaining that flexibility and openness necessary for providing neurodiversity-oriented care. These are systems level things that behavioral health professionals can try to integrate into their daily practices.
Excellent, Emily, thank you. Ben, what do you think? Using that as a backdrop, what should be our approach to folks with IDD, and what are your thoughts on where we go with this?
Well, really, what we've seen, I think I totally agree with and echo what Emily is saying. I think what we've seen is an amplification of the same issues that we've been dealing with for quite a long time, and that is the core mission of Aadmd. Exactly what you're talking about, the beyond access to care, access to competent care for individuals with IDD. Partnering with medical schools is going to be critical to addressing the complex health needs, including the mental health of individuals with IDD. Specific to what we learned in the pandemic and how to adapt and where we go forward is, we learned that mental health care is not just access to a psychologist and a behavioral health team, but access to Special Olympics services, access to regular, competent, professionalized staff that knows you well and knows how to listen and can address your needs, that when staff is sick and family who knows you well are sick and you're isolated and you're with unfamiliar people, that is an enormous mental health risk. So if anything, supporting those who support those who we care for is going to be a critical thing to pay attention to in the future. Clinically, in practice, we see the limitations of telemedicine, but we also see the tremendous opportunity for interdisciplinary and collaborative care. The fact that now I'm comfortable and fluent and able to collaborate with colleagues all over the world in this very comfortable video space is amazing. The fact that I can see someone in my office who can't necessarily communicate everything I need to be able to team up with them to address an issue, and they may be with covering staff, but I can now on a video call have a hybrid of a nurse, a behavioral clinician, direct care staff, family, and everyone who can help us solve a puzzle of a really challenging problem that we need to address, that before would take 5 or 6 visits to be able to figure out, but that a keen observer who's now available to speak with us might be able to share. There are a lot of tremendous opportunities for the utilization of this technology that we've now really become so fluent and comfortable with, that it's now ubiquitous. So I see a bright future, and I don't think we've let this crisis go to waste. Certainly, as far as adapting, I think we're here and we're doing it. You know, although you know, there's certain ideas and concepts that are sort of applied everywhere. The Pauli's exclusion principle, the cat experiment, and the Kubler-Ross stages of grief. But in this case, we're going through them all at the same time. Really, it's anything that is really hard for all of us to accept, any enormous change. We're going to see culturally and personally, we're going to go through denial. We're going to go through anger, and we're going to go through these fits and spurts together. But we're coming to accept that there are going to be times when we all have to mask up, and then there are going to be times when we don't need to be as vigilant. There are going to be times when we have to meet exclusively via video, and there are going to be times when we can get together and very comfortably see our patients in person. So we're there. We're moving back and forth between more precautions and less. And again, just looking forward to a bright future, utilizing the tools that we're now figuring out and advocating for the individuals and those who care for them.
Excellent, excellent. Thank you. It's such a glass half full perspective. And gosh, after 2 years of glass half empty, how lovely to be in the company of a bunch of folks who see the glass as half full. It's that time of the program. Here's the question. So I've spent 90 minutes with you guys and have loved every minute of it. I've learned a ton, but I want you to put me to work. So each of you, in a minute, tell me, what do I do tomorrow morning when I show up to my office, or I turn up to my program, or I go off to my job, or I just wake up in my home, zesty, ready to rock? What one thing do I do? Kim, I'm starting with you.
That's a great question. I'd say, first of all, it's in the morning. Go to your coffee pot and pour yourself a cup of coffee, get your muffin, sit down at your desk, you know, answer your emails, answer your phone messages, just start your day. You gotta keep going, right? The life continues on until it doesn't, right? And you just gotta keep going. You know, you got to do all your day-to-day things and then take on something that you're interested in. As far as advocacy goes, obviously, one person can't do all of the various things. There's so many areas that need addressing. So pick which one you're most interested in, most qualified to do something about. I know I'm on Medicaid, my sister's on Medicaid, but we have different providers. And she was not able to get any medical care, period. Nobody had telehealth in the Medicaid system. And if you're a healthcare provider, right? I mean, she went a whole year without a single visit to a psychiatrist.
Yep.
That's unacceptable. If you're in such a position, please do something. Get telehealth. Do something so that people don't go without any services for over a year. If you are in a position where you can do something to get technology into the hands of people, to get internet into the hands of people, please make that your mission. Choose something that you can do. And if you have not had any experience as a medical professional working with the IDD population, there are avenues that you can do this. Special Olympics has a wonderful program where medical professionals come in, and at different competitions, they have this whole setup where you can get your eyes. I got glasses. I mean, you can interact and help work with the IDD population. These things are out there. Please take advantage of them.
I love it. I love it. Here's the best part of that one. Wake up and smell the coffee. I think that's what I heard. I love it. Thank you. Emily, what do I do tomorrow?
I'm going to make a call to my fellow researchers and say, reach out to the community that you're studying. Don't just study them, reach out to them. It doesn't have to be some big thing, some big community-based participatory action research study that integrates theory and all these fancy methods and approaches. Ask them what's important, get their feedback on your measures, get their feedback on your overall research proposal. Just reach out to the community and integrate their perspectives into your work.
Outstanding. Ben, what do I do tomorrow?
I agree with Kim 100%. Let's adapt. Let's keep going, and let's use what we've learned going forward. But and also I just want to hope that while there's so much anger and frustration sort of in the air, it's like crackling with disrespect and anger toward each other, that I think our community is in of IDD care providers is in a unique position, because there are such fundamental issues that we disagree on so strongly, that even that Professor Hotez was coming on to earlier, and these have been amplified during this time. But we are in the unique position of embodying inclusion and respect, and so I'm looking forward to continuing on and hopefully being a part of positive change going forward. And I'm gonna do what Kim says to do.
All right, John, I give you the last word. What do I do tomorrow, sir?
Absolutely what Kim advised. Make sure the coffee is good. Life is too short for rotten coffee. All kidding aside, though, I think we have all been in a collective trauma. All of us, our whole planet. And you said it, Ben, we are snapping at each other. We have short fuses. David, I'm going to say it. I'm going to put the L word out there. We need to love each other, and we need to see each other in the perspective of this post-pandemic, living well with this pandemic, moving forward. We need to be much more respectful of each other. And I think that's missing. As related to what you can do as an executive working with direct support professionals, talk to them, see them, tell them they're seen, tell them you're advocating for them, do anything you can do. And again, like what Kim said, put into their hands what they can use to support people. Whatever those things are, whether it's technology, whether it's N95 masks, I don't care. That's your role. But look at those direct support professionals as precious, not heroes, not angels, but professionals that are doing incredible work to keep people safe, connected, and loved. That's my advice, David. Go do it. Go do it tomorrow.
Thank you, John. I will. Wow. Dr. Wong, this is one heck of a panel, man. And this has been a lot of fun. You guys absolutely rocked it. So thank you. Thank you to all of the hundreds of people. We will get to questions, I promise. Alan,
well, thank you.
Pass the baton to you, sir.
Thank you, David. What an excellent job as a moderator. And I love you all on John's behalf. But I just say this is so rewarding to hear, because moving forward, we have to look forward. And as Zig Ziglar said, it's not the aptitude, it's your attitude that determines your altitude. And I know that going forward, we're going to do much, much better and learn from this terrible thing about telehealth, teledentistry. Dental needs are probably number one unmet needs, but we've learned to use dental health to help take people out of pain. So we have to learn from that. We have to empower one another to talk more with one another and advocate for one another. A grassroots movement is everyone here on this conversation, you know other professionals, you know dentists. You ask them, are you seeing patients with IDD? Why not? Have you tried telehealth? We need to start supporting one another. If you know people going to institutions, research. How about sending people to research? How about DSPs? We need to sort of understand them more. I learned so much more during this time. I myself had COVID. I was in ICU for 4 weeks. I warded off the ventilator 3 times. All through that time, I said to myself, no patient should have to go through this. So afterwards, we created vaccine clinics for people with intellectual disability and their families. We need to keep doing this and making sure that people are safe. We need to also encourage self-help, mental health, improving each other's immunity. Let's not be held and be cloistered in a room. Let's think about improving our self-immunity and our therapeutics and advocacy. But that's what AADMD is all about. It's about a community, all of you together, with us together, sharing with each other our barriers and our challenges. And I'm looking forward that we will get past this further as long as we learn from the past and look at the brighter future. So David, thank you once again for a wonderful job in moderating. Again, all these wonderful questions, and we will get those answered. And we'll see Dr. Peter Hotez gives us some answers about this. So that's just a little teaser. Thank you everyone for being with us in here today. Courtney, can you share an invitation? Our invitation is to anyone who would like to join us at the AADMD annual session. It's going to be right before the US Games for Special Olympics in Orlando, Florida. We are hosting a bunch of wonderful people, including the the AMA, the American Medical Association president, the ADA, the American Dental Association president, some folks from the White House, CDC is going to be there, Tim Shriver, and very many other wonderful guests will be joining us. The National Council on Disability, Rick Rader, the famous Dr. Rick Rader will be with us. And after the 5th, it goes from 3rd to 5th, the 6th starts our US Games with Special Olympics with over 4,500 Special Olympic athletes. So it's going to be a wonderful week of celebrating, of moving forward. And we are the voice for inclusive health, the one voice. And as we move forward, we look forward to great changes for the better. So thank you again for joining us all. Courtney, do we have any last words?
Just cue the video.
Just cue the video. There you go. Thank you, everyone, and have a great Valentine's Day. Thank you, wonderful panelists. I love you all.